Hello everyone, my name is Rob Cooper. I'm a cardiologist specialising in cardiomyopathy and sport cardiology based in Liverpool in the northwest of England. I've been asked to talk to you today about the return to play protocols for our professional athletes and getting them back onto the field of play following a COVID illness, specifically with regards to the risk of contracting myocarditis and return to play if we find it. The plan for this presentation is to talk to you in four main sections. Why do we worry about myocarditis in sport? Is it of relevance? Does COVID indeed cause myocarditis? How in the world of cardiology would we diagnose myocarditis in these athletes? And what cardiac protocols post-COVID should we be following to clear these athletes for return to play? And I'm going to talk to you about a couple of case studies where we were able to get our athletes back into their sport. So, why do we worry about myocarditis in sport? Fortunately, sudden cardiac death in sport is infrequent. The incidence of sudden cardiac death is low, and the prevalence of a condition that puts people at risk of sudden cardiac death is around 1 in 250. This is why we have a low pickup rate with pre-participation screening, but it is important to find these athletes when we do. The average age is around 23 years, but 40% of these will be teenagers. And there is a preponderance towards male athletes with a ratio of 9:1 of males to females. The ethnicity of athletes can hold some consideration when thinking about the underlying pathophysiology, as most of our data is in Caucasian white athletes, although recent years have allowed us to understand the black athlete in some more detail. If we look at sudden cardiac death in athletes, specifically in the United States, dating back 15 years now, we see that a lot of it is attributable to hypertrophic cardiomyopathy, with a fair proportion, around 1 in 7, being due to coronary abnormality. In here, we see that 7% of these athletes were found to have myocarditis in a post-mortem following sudden cardiac death on their field of play. This is the American data. When we contrast this with the Italian data of the same time period, we see that there is a very small amount of hypertrophic cardiomyopathy, but a much greater percentage of arrhythmogenic right ventricular cardiomyopathy. Now, importantly, this group had cardiac screening prior to participation in sport, and it may well have been that a lot of these athletes who were found to have hypertrophic cardiomyopathy were not allowed to play. In this series, we did not see any myocarditis. If we then look at the UK experience of young sudden cardiac death, we see that a large majority, 42% indeed, were due to sudden arrhythmic death syndrome, where nothing was found on a detailed expert post-mortem analysis. This is largely channelopathies such as long QT syndrome, Garda syndrome. We do see a small amount of myocarditis, so just 2%. If we then look specifically at football and the FIFA registry over 14 years, we see that 4 to 5% of these sudden cardiac deaths on the field of play of 211 deaths were due to myocarditis. Myocarditis is common in military deaths also, and this is a comparable population as they are young and are screened before going into the military. In this series, they found that 20% of sudden cardiac death was attributable to myocarditis. What is myocarditis? Well, the name gives it away. It's an inflammation of the heart muscle. An inflammation and unstable myocardium causes abnormal electrical passage through this myocardium, and there is therefore a risk of ventricular arrhythmia. We see this as 0 to 7% of sports sudden cardiac deaths, 4 to 5% on field in football or soccer, and 20% of sudden cardiac death in military recruits. So it does have some risk of causing dangerous ventricular arrhythmias on the field of play if present. So it's proposed to be responsible for sudden cardiac death in a series of young people, namely athletes. So we're right to worry about myocarditis in sport. Does COVID cause myocarditis? We're constantly learning about COVID. It's only been with us for a year, and the first series to come out of Wuhan did describe their clinical outcomes of hospitalized patients. They were a relatively small series with around 40 patients, around a third of which were in intensive care, the rest being cared for in hospital on oxygen. There were detailed reports with regards to their clinical outcomes, and in here we can tease out the cardiac enzymes, the most sensitive of which would be the troponin. And we see that the troponin was elevated in those patients in hospital with COVID, in around a third of people in intensive care and around 1 in 20 of those who were hospitalized outside of intensive care. The other markers are less sensitive for cardiac damage. So there is some cardiac irritation in this first series from Wuhan. This then started lots of academics considering what exactly is the cause of troponin release, and there are many possibilities, many mechanisms of cardiac injury. We see that SARS-CoV can irritate endothelial cells, causing microvascular dysfunction. It can also irritate the endothelial cells in coronary arteries and cause a pro-inflammatory state with plaque instability, leading to myocardial infarction or an acute coronary syndrome. Importantly, there is significant body-wide inflammation, and those that end up in intensive care often have the cytokine storm that produces a systemic inflammatory response syndrome similar to sepsis. Interleukins are part of this and are not fully understood yet. It is proposed that this cytokine storm can contribute towards myocarditis. There is also the possibility of direct viral irritation of the myocardium. This myocarditis can lead to heart failure and leads to unstable heart rhythms, can lead to ventricular arrhythmia and death. So we have a systemic inflammatory response to cytokine storm as a potential. We have profound hypoxemia from respiratory illness, because remember, this is predominantly an airways disease. Because of the significant airways disease in the lungs, we see significant hypoxemia and pulmonary hypertension. This can put strain on the right ventricle. The right ventricle has myocardium also and can release troponin, much like you would see in a pulmonary embolism. Vasoconstriction or thromboembolic complications are also a possibility, and up to a quarter of patients on intensive care for COVID will have some evidence of pulmonary embolus. There is also the possibility of inflammatory atherosclerotic plaque rupture and acute coronary syndrome. The one that concerns us most when it comes to myocarditis is direct viral infiltration, much like viral myocarditis before COVID. So once these first series have come out of Wuhan with regards to troponin and other cardiac enzyme elevation, we started to see a smattering of case reports of acute myocarditis. Now, this was spring, early summer in 2020. And this was when most of, certainly the UK society and a lot of societies around the world were closed down. People were in lockdown. When you look at these papers in a bit more detail, there were some series coming out of, again, China, with regards to cardiac MRI to try to understand the cause of troponin release. There were only 20 patients in this study, and there was some evidence that there was water in the extracellular components of the myocardium. The myocardium is meant to be comprised of myocardial cells with very little in the extracellular or interstitial space. And in this paper, they show some MRI pictures as examples of myocarditis. Now, a lot of these pictures look like a normal heart. This is not myocarditis. This inferior insertion point fibrosis or late enhancement is seen in pulmonary hypertension, it's seen in athletes. It is not specific for myocarditis. This is a typical pattern of myocarditis with more pronounced late gadolinium enhancement in the epicardial surface of the myocardium. This is not what any of the pictures in this paper. We then come to the paper that caused quite a stir. This was from a German series and was responsible for closing down the Big Ten in the United States with regards to college sports. It studied 100 patients with cardiac MRI, aged around 49 years. This was performed an average of 71 days after recovery, with 2/3 of these patients not requiring hospitalization, and only 1/3 actually reaching hospitalization as an indication of the severity of their disease. The high sensitivity troponin was detectable at some level in 71%, although only actually raised in less than 10%. And they commented on lots of MRI markers that were deemed to be abnormal. A native T1 mapping value is indicative of how much of the heart mass is outside of myocytes, so space in between heart muscle cells or interstitial space. A T2 mapping value is very sensitive for water content. And water content is deemed to be responsible for edema, myocardial edema, which is seen in inflammatory states. And they also commented on being able to see late gadolinium enhancement, which they proposed would due to fibrosis in up to 1/3 of patients. So 100 patients who are middle-aged, 2.5 months after their injury, 2/3 of which were not particularly unwell, and a third requiring hospitalization. They were quite markedly abnormal MRI markers. So this caused quite a stir in the MRI and in sports cardiology circle. But if we look a little bit more closely at this paper, there were some discrepancies with regards to the data. And this actually caused an adaptation and retraction of some of the data from the authors. What was first commented on is 100 patients who had COVID-19 and healthy controls. And they compared things like late gadolinium enhancement and native T2 or water marker, or native T1 extracellular marker in patients who had COVID-19 against healthy age-matched controls. So people with no conditions, no background blood pressure, no background heart disease, no background diabetes. And they found really significant differences between markers of extracellular space in T1, water in T2, and gadolinium enhancement, with a third having gadolinium enhancement who had COVID and none of the healthy controls. But when you try to then match risk factor matched controls, so not healthy controls, patients who had similar disease processes as those who had COVID-19, so for example, diabetes, high blood pressure, coronary disease, we see less of a marked difference. And we see this T1 value creeping up to what we spotted post-COVID at 1,111 versus 1,125. We see the T2 value creeping up towards what we see in COVID. And we see some late gadolinium enhancement on the MRI sequences. We then see this as a scatter plot. So these were the healthy controls at the initial comparison cohort. These are patients who had COVID-19 who had recovered at home, so not as severe, and these are patients who had COVID-19 who were hospitalized, who had more significant illness. This graph is for native T1, and this graph is for native T2. And we see those that had COVID having higher values generally, okay? But when you unmask those who had risk factor matched controls, so those who had underlying health disorders, we see that it's a lot closer to those who had COVID-19. So of this paper, some of the data wasn't quite correct. And some of it, when matched correctly, was observed in patients who had not necessarily had COVID-19, but had the same underlying health conditions. So the conditions that put patients at risk of having a more significant illness with COVID also alter the parameters you are measuring. People who have high blood pressure, people who have coronary disease, people who have diabetes, people who are obese, have a greater risk of having COVID and also have a greater risk of having these abnormal parameters. So it is the pre-existing disease that's caused these subtle measurable changes in cardiac MRI, not the COVID illness. One of the best ways to look at what's actually happening in tissue is pathology. Now, in pathology, we are largely restricted to those patients who have died and therefore by definition have a severe disease. This was a successive series of 16 postmortems carried out in patients who passed during their COVID-19. Largely this was due to diffuse alveolar disease or bronchopneumonia. Interestingly, in those patients, 16 patients who died, nearly all of them had a pericardial effusion, with only one that did not have. We also see that in these deaths, only 2 had viral DNA measurable in myocardial biopsy samples. So despite the severe illness, despite the severe lung disease, despite the pericardial effusions, very few actually had virus in their heart. And this is a highly selected group of patients with severe illness. The conclusion was that myocarditis is uncommon in autopsy at endomyocardial biopsy in cases of COVID-19. This is in severe illness, not your asymptomatic or 2 or 3 days worth of snuffle that we see in our professional. So how about to be able to look at a series of athletes who had mild or moderate disease with their COVID? This was a Polish group of 26 successive athletes, predominantly women actually, across a variety of sports. A quarter were asymptomatic, half had mild disease, with only 1 requiring hospitalization, with relatively modest levels of troponin measurable. There were no significant resting ECG changes. And of the MRI measurements, there was normal left ventricular size, normal left ventricular function, normal markers of extracellular space in T1, and normal markers of extracellular water in T2. There was only 1 example of having any late gadolinium enhancements, and this was defined to be in a mid-wall non-ischemic pattern, with 2 of these athletes having pericardial effusion. The conclusion was that in a small group who had asymptomatic to mild COVID, if these patients did not have ECG changes and had normal troponin, their MRI were normal. Interestingly, 19% of these athletes had some change on their MRI scan, which is not necessarily attributable to COVID. This is observations of athletic. So, does COVID cause myocarditis? In severe COVID, there is definitely cardiac irritation. We see this through cardiac enzyme. There are many potential mechanisms for this, of which viral infiltration is not the most likely. And direct viral damage seems unlikely in asymptomatic or mild COVID, which is what we're dealing with in most of our competitive athletes. So, how in the world of sports cardiology would we diagnose myocarditis if we went looking for it? Blood cardiac enzymes are very sensitive for myocarditis, troponin being one of the most useful. These were old series, so these are not high sensitivity to current troponin assays. But we see in terms of the severity of myocarditis, it is clear that in the more diffuse global myocardial disease, we see a higher measurement of troponin. And when we have no disease versus a minimal syndrome, a moderate syndrome, and a severe syndrome, it is correlative. So the more significant the myocarditis, the more significant the troponin release. Serum troponin is a very sensitive marker of myocardial irritation, regardless of the cause of irritation. ECG changes in myocarditis can be quite non-specific. They're largely related to ST segment and T-wave changes. And this is where it's really useful to have a baseline ECG in athletes, because they often will have some ST segment and T-wave changes as part of their athletic adaptation. In this example, we see some lateral T-wave inversion, so V4, V5, V6, lead 1 and lead AVL. This is an abnormal ECG. This is not athletic adaptation. In this example, we see some subtle ST elevation. Now, this was a patient with myocarditis, and this sort of ST elevation could be passed off as being a normal training-related change if interpreted in the appropriate clinical context. Echocardiography is an excellent tool for looking at the heart. It's the most available cardiac imaging modality. It is portable, rapid, and available, and part of most football screening protocols. The Football Association will mandate in the UK an echocardiogram as part of late teenage screening for signing professional contracts. And it's really good at looking for cardiomyopathy, so either hypertrophic, arrhythmogenic cardiomyopathy, dilated cardiomyopathy. It is, however, less sensitive for myocarditis. In a severe illness, we can see clear abnormalities of left ventricular size and function, with often regional or most abnormality of the area that's affected by myocarditis. But it's more challenging to make a diagnosis of mild to moderate myocarditis that might not cause quite so global dysfunction. When we are trying to understand how good echocardiography is at diagnosing myocarditis, the gold standard to compare it to is cardiac MRI. In this series of patients, age 32, who had a clinically significant hospitalized myocarditis, this is non-COVID, this is pre-COVID viral myocarditis. We see that the left ventricular ejection fraction was largely preserved, and these are hospitalized sick patients, the mean value being 54%. Some went down to 43%. They were the more significantly affected individuals. One subtle marker is global longitudinal strain. This is a marker of systolic deformation, and if done correctly, can be a more sensitive early marker of dysfunction than ejection fraction. And sometimes with regional abnormalities, you can see this on the echo strain map. So this is an example of an MRI picture. Normal myocardium here in this circle of left ventricle is a grayish color. In this white area, we see water, and this is active inflammation. In a matched echocardiogram, we see lower strain values. So this is movement that is not as strong, not as good. So echo can be okay in severe myocarditis. These patients had a peak troponin of 960, which is quite significant. And when we consider the amount of edema of the left ventricle along the x-axis as measured by the cardiac MRI, and the global longitudinal strain along the y-axis as an echocardiogram measure, anything in this area would be deemed to be abnormal. So anything higher up the y-axis than minus 15%. Now, to get there, you have to have greater than 10% of your left ventricle affected by edema, by irritation and inflammation, which is quite a significant amount. So even the most sensitive marker on an echocardiogram changes quite late into a severity scale on myocarditis. Then we come to cardiac MRI, which is the gold standard for imaging in a diagnosis of myocarditis because it gives you function, it also measures inflammation, and it measures scar. Here we see a 4-chamber example of functional MRI. So this light grey is blood inside the heart and the right atrium, then right ventricle, left atrium, left ventricle. And we need to take many perspectives to look at the different areas of the heart. So this is a 3-chamber view where we see blood come from the left atrium into left ventricle, and then out of the aorta. And this is a short axis where we see the circle left ventricular muscle squeezing in together. Myocardial content is the greatest incremental information you get from a cardiac MRI above echocardiogram. Here we have T2 mapping, and this gives you a numerical value as to how long the spin of a proton takes to return to normal in a myocardial, a magnetic resonance imaging scanner. Generally, values above 52 or 53 are deemed to be abnormal. So in the anteroseptal segment here, 51 is okay, but in the lateral segment, 62, 64, this is abnormal. On the correlative T2 weighted stare image, we see high signal. So this is water in its myocardium versus normal myocardium. And the late gadolinium enhanced, we see fibrosis, late gadolinium enhanced, and the epicardium outside of the myocardium. In this example, we see some really high T2 values, 74. And we see this really grossly diffuse inflammation in this T2 weighted sequence and really dense late gadolinium enhancement. This is severe myocarditis. So we can see numerical value for water content. We can see a visual representation of edema in a stare image, and we can see late gadolinium enhancement, indicative that the myocardium is abnormal. This is all above and beyond what you get in an echocardiogram. So when looking at clinical diagnosis of myocarditis, the adapted Lake Louise criteria 2018 are used. We have a clinical syndrome that is in keeping with myocarditis first and foremost. So symptoms such as chest pain, breathlessness, ECG changes, troponin markers being elevated. We then need 2 markers on an MRI scan: active myocardial edema, T2 mapping or T2 weighted sequences, and non-ischemic myocardial injury. This is usually by late gadolinium enhancement in a non-infarct pattern, so non-subendocardial. So, how do we diagnose myocarditis? Blood, ECG, taking pictures of the heart. Troponin is very, very sensitive. If it's negative, it's very unlikely to be myocarditis. It's probably the most sensitive test we have. The ECG is a very good tool, but it's useful to have a baseline to know whether some subtle ST segment and T-wave changes are long-standing athletic adaptation or acute myocarditis. Echocardiogram is useful because we use this a lot in sports cardiology and we are very comfortable with it. It is mobile, it is available, it is cheap, and it's useful for significant myocarditis. With an MRI, a cardiac MRI scan is the gold standard and gives you information above and beyond the echocardiogram with inflammation and myocardial damage. Okay, now I move on to what cardiac protocols post-COVID should we follow to clear our athletes to get back onto the pitch. There is a general consensus across European sports cardiology groups following a categorization of asymptomatic, mild illness, moderate illness, and severe illness, which generally requires hospitalization. For the asymptomatic group, there is a simple return to play protocol that does not necessarily involve any cardiac testing. If the symptoms have settled and they have been gone for at least a week, start a graded return to play protocol with the sports scientist, physiotherapist, and sports doctors. In a mild illness defined as athlete recovered from COVID-19 and symptom-free for at least 7 days with 10 days passed since the onset of symptoms, these patients can have a 12-lead ECG and echocardiogram. If these tests are normal, they can return to play. If they are abnormal, we then move on to a cardiac MRI, ambulatory ECG, also known as a Holter monitor, troponin testing, and cardiopulmonary exercise testing. If they're normal, they return to play. If they are abnormal, this needs specific input from a specialized cardiologist. And those with moderate illness, so those who have not recovered from COVID-19 for greater than 14 days from symptom onset. And these symptoms can be anything that is associated with COVID-19. The suggestion is a 12-lead ECG and a cardiac MRI to look for more accurate information about inflammation. We've also then introduced blood tests, including a troponin, D-dimer as a marker of thrombosis, and a CRP as a marker of inflammation. If they're normal, we can exercise and arrange ambulatory ECG, and if normal, then return to play. But any abnormalities along this path or any severe illness requires the input of a sports cardiologist or specialist cardiologist. North American guidance has a similar approach in splitting into asymptomatic, mild, moderate symptoms, or severe symptoms for hospitalized patients. They agree that those who are genuinely asymptomatic, who are self-isolated for 10 days or more and have no symptoms, can return to play following advice from sports scientists, physiotherapists, and sports doctors without the need for cardiology input. They also state that those who have mild symptoms do not necessarily need any further testing and they don't have any concerning symptoms and no protracted course of illness. Those with moderate symptoms do need cardiac assessments, and this is evaluation by a medical professional and requires ECG, troponin at this stage, and an echocardiogram. If all normal, return to play. If abnormal, then go on to further testing with cardiac MRI, and then consider the role of ambulatory ECG and provocation with exercise testing. And this is where you need to involve a specialist cardiologist. So a short summary of the tests that are recommended after COVID-19. If there are genuinely no symptoms, it's probably nothing is required from a cardiac safety to play. The argument can be made for questionnaire, clinic review, and ECG, because there are some subtle changes in ECG, then you can ask more questions. If it is as it was before, you can be reassured they're safe to return. In a mild illness, a questionnaire, clinic review, and ECG seem sensible, and Europeans would suggest an echocardiogram is a good idea. In moderate illness, questionnaire, so asking symptoms of, particularly of cardiac illness, so things like chest pain, disproportionate breathlessness, pre-syncope, syncope, palpitations. ECG is a requirement, an echocardiogram is a requirement, and perhaps a cardiac MRI would be more useful. And those with severe illness really should be dealt with by specialists in cardiology. And in that stage, we need to look at cardiac MRI, ambulatory ECG monitoring, and exercise test provocation. If there is a proven myocarditis, we have to strongly consider the prospect of several months off competitive sport, including training. You should undergo a comprehensive evaluation using imaging studies to look at the way the heart appears, but also look at the way the electricity of the heart behaves, so Holter monitoring, ambulatory ECG. Exercise testing is also sensible, and return to all forms of exercise should be considered 3 to 6 months once patients are asymptomatic and markers of inflammation have settled down. So biochemical markers such as troponin and MRI markers such as T2 weighted sequences or sometimes T1 weighted sequences. Things you should not do. Those with a probable or recent diagnosis of myocarditis should not participate in even leisure time sports while active inflammation is present. You should wait 3 to 6 months once the patient or player is asymptomatic and all inflammation has settled, troponin and MRI. You should not exercise whilst there is active myocardial inflammation. This is pro-arrhythmic and runs the risk of sudden cardiac death related to ventricular arrhythmia. There's no high intensity exercise for 3 to 6 months. After a myocarditis, if there is persistent scar, they need risk stratification with exercise testing and ECGs. And if there is significant subsequent left ventricular systolic dysfunction, the athlete may be advised not to return to competitive play. Bearing in mind these 4 points, why do we worry about myocarditis? Does COVID even cause myocarditis? How do we diagnose myocarditis? And what protocols should we use? I'm going to go through a couple of case studies. Part of the remit of sports cardiology is to encourage our athletes to be competitive. It's not necessary to restrict and restrain at all opportunities. The first case I'm going to present is dating back to late spring in 2020. This was after the first UK lockdown as we were easing the rules, and it was return to play of the English Premier League. Our player here was playing in the Premier League and had COVID 5 or 6 weeks earlier with a very minimal clinical illness. Fever for a couple of days, a little bit of muscle aches, but no issues with oxygenation, did not require hospitalization, was isolating at home quite comfortably. This was 6 weeks earlier. On return to play assessment as part of the Premier League return to play assessment, he had a full blood count of CRP, which is normal, but a high sensitivity troponin was positive. And it was positive at around 4 times the upper range of normal. So this was a number that we could not ignore. Prior to coming back to the cardiac assessment for return to play, all athletes were supposed to be doing mat-based training only. There was no outside running or exercise advocated. This is our ECG. We see sinus rhythm. We see a relatively slow heart rate. We see a normal PR interval with a partial right bundle branch block in V1, which is not uncommon in athletes. We also see some subtle T-wave changes with inversion in lead 3 and biphasic T-waves in AVF, which again can be attributable to athletic status. They could, however, be indicative of a local myocarditis. We then move on to our cardiac MRI pictures. And these give us really good information about the function of the heart, and particularly of the left ventricle. This function was normal. The systolic squeeze was normal. The stroke volume, the amount of blood that gets out of the heart per beat, was normal. There were no regional abnormalities to indicate that some part of the muscle was struggling with an irritant of some description. We then move on to our late gadolinium enhancement sequences. So the principle of late gadolinium is we inject a contrast agent with gadolinium, which has paramagnetic properties, and take pictures 8 to 10 minutes later. So these are late pictures. If there is normal myocardium, the contrast agent with the gadolinium will have passed through and there will be no signal from the myocardium, hence a black appearance. If there is a white appearance, it suggests that the contrast agent has been held up in that myocardium and something is abnormal about that piece of heart muscle. Now here, in the basal lateral wall, we see mid to epicardial fibrosis. And this is our athlete who had an elevated troponin. In this circumstance, it is very, very useful to have some markers of acute inflammation. So our native T2 pictures come out looking like this. And what we're looking for are areas that are bright. So this is blood inside the left ventricle. The myocardium, if it was edematous, would show areas with bright signal like this. And we see nothing on the short axis. We see nothing on this long axis. The T1 value gives you an idea about extracellular space. So if there was myocardial inflammation, there would be extracellular edema, and this value would also be elevated. And we see no elevation in these short axis pictures on the long axis pictures. So these images were normal. So what now? We stop and we think. COVID positive 6 weeks ago with a minimal clinical illness. A troponin positive 6 weeks later. Myocardial scar on an MRI scan, but no active inflammation on high quality specific sequences done on the MRI scan. We moved on to trying to understand the risk of this myocarditis. Rhythm monitoring, so the ambulatory ECG was normal. We had 48 hours with not a single ectopic and no arrhythmia. So no ectopy in a clinical syndrome that we are presuming has some inflammation is very unlikely. We also repeat his serum troponin 2 days later, and this is normal. Less than the normal range at 8 nanograms per litre now. We go on to cardiopulmonary exercise testing. So this gives us an idea about ECG and rhythm, gives us an idea about blood pressure response, but also targets respiratory parameters and tells us about fitness. We use a bicycle ergometer in those who we think have a clinical illness in this category, and possible myocarditis falls into this category. The fitness level was very high for somebody who was supposedly doing no training for 6 weeks and doing only mat-based yoga. And importantly, there were no provocable arrhythmias. So we go back to our history. He had started training. The day before the testing, he'd been out and done 5 1-kilometer sprints. So interval training. The original testing protocol was in the context of a rest period and mat-based exercise only. When we consider exercise and troponin release, we know that significant levels of exercise can cause short-lived troponin release, and that it is more significant in those who do more significant exercise. So when you compare 10-kilometer runners to half marathon runners, we see a marked jump up to half marathon, but those that do a marathon have an even bigger incremental rise in their troponin. So this is slow and steady. This is long endurance exercise, but not what our athletes had described. If we then look at exercise intensity, so the same athletes going through different exercise programs from low and slow 10-kilometer runs to high intensity, short burst runs. And we see that the high intensity causes quite a significant incremental rise in troponin versus the low and slow. But importantly, when you get to 48 hours, all have returned to normal. This is not true in acute myocardial infarction. This is not true in acute myocarditis. You do not see a return to normal within 48 hours. So the troponin elevation 6 weeks post-COVID was related to training. It was a rapid drop to normal. And this is a different type of troponin release, cardiomyocyte permeability, different mechanisms, different kinetics than acute myocardial infarction. The scar on the MRI scan was old. It was not acute. There was no active inflammation. There were no signs of risk on ambulatory ECG and exercise testing. So he was allowed back to play in the EPL with everybody else and has had no issues since then. Our second case is also a professional footballer with a relatively mild illness, 3 days worth of sore throat, fatigue and malaise. He had a positive COVID test, but the CT count gradually came down and had a negative test 10 days later. So this is a mild illness. As part of his return to play assessment, he had clinical review, ECG and echocardiogram. This was his 12-lead ECG. Now, importantly in here, I want to point out some changes in the lateral chest leads, V4, V5, V6. This shows some ST segment elevation. Now, ST segment elevation has to be taken in clinical context. This is unlikely to be an acute myocardial infarction. Can be an athletic adaptation, but equally can be myocarditis. We also see uncomfortable changes in the limb leads. T-wave inversion in lead 1, T-wave inversion in AVL. This is abnormal. This is not an athletic change. Curiously, we also see ST segment and elevation and T-waves being upright in AVL, which is a very uncommon finding. Okay, this points towards there either being a significant global myocardial change, for example, left main stenosis in coronary artery disease, or fulminant myocarditis, or perhaps an error with the acquisition of the ECG. Bear in mind that this was an athlete who at this time was well and had a mild illness. So seeing an upright T-wave in AVR is unusual. He progressed to an echocardiogram, which showed normal left ventricular size and geometry, so there was no hypertrophy, the cavity size was appropriately dilated. The left ventricular ejection fraction is a little bit reduced, but we know that anything above 52% or so in male athletes is acceptable, with a borderline reduction in global longitudinal strain, but no regional changes to suggest that one part of the heart was struggling more than others. Normal right heart, normal valves, no pericardial effusion. At this time, the troponin that was tested was normal. So he went on to have an MRI scan. Now this, excuse the shaky pictures, shows normal left ventricular size and function, but interestingly shows some pericardial collection in the basal inferior wall here. This white area is fluid in the pericardium, which we see on this picture here. This is the same effusion. And also down at the apex of the heart, we see some fluid accumulating over the right ventricle. Okay, so we now have someone with an abnormal ECG, normal troponins, a pericardial effusion. Do you remember your pathology studies? There were pericardial effusions in all of those that had a post-mortem as part of pathology studies. The late gadolinium enhancement pictures were important. They showed some inferior insertion point enhancement. Okay, this was deemed to be myocarditis, and we did not have the benefit of acquiring any specific inflammation sequences to know whether this is active water content as a result of edema or whether this is just an observation. The assessment on the cardiac MRI of the size and function matched the echocardiogram, so no great concerns. But we now have someone with an abnormal ECG, perhaps some late gadolinium enhancement, and a pericardial effusion. You have to stop and think again. It's useful to reflect on the tests that you've done when thinking what to do next, especially when you're making important decisions about returning to play and labeling people with significant disease processes. We have a mild clinical illness, an abnormal ECG on the surface of it, a normal echocardiogram for an athlete, but an MRI with a couple of important findings. At this stage, this athlete was diagnosed with myocarditis and was told they would be 3 to 6 months away from physical activity. Let's consider this again. It's really important that he had a mild illness. When we look back at the earlier slides about does COVID cause myocarditis and the extent of cardiac irritation with mild COVID illness, we have to worry about this being a real cause of myocarditis. We have suspicions about the ECG. We're going to repeat that. Can these abnormalities on an MRI scan be explained by other reasons? They're not typical of myocarditis, and there were no active edema sequences. And importantly in all of this, we have a normal troponin. One of our most sensitive markers of myocardial irritation was normal. So we repeat the ECG. This makes everybody feel a lot more comfortable. AVR looks like AVR should. T-wave inversions now. This suggests to me that the electrodes on the limbs on the first ECG were put on the wrong limbs and we were measuring the wrong vectors. We now see that the T-waves in lead 1 are upright and normal, and in lead AVL are upright and normal. So the T-wave inversion that we'd labelled as being pathological earlier was likely due to an error with acquisition of the ECG. We then think long and hard about labelling this late cardiac management as COVID myocarditis. We see inferior insertion point in up to a quarter of athletes, and it's generally asymptomatic. It might be related to repeated bouts of exertion and is seen without myocarditis. This image from the Fibrosis Athletes Current Perspective paper by one of the most eminent cardiac MRI cardiologists in the UK, Chiara, almost exactly matches the MRI picture from our athlete. Then we have a closer look at some of the MRI pictures, and we can see that there is a chest wall deformity for this athlete. There is a pectus excavatum. In those with a pectus excavatum, there is some subtle pressure in the right ventricle that is not pathological, it is not worrying, but does cause some subtle changes. And we see, if you look at an MRI scan, a pericardial effusion in up to 56% of these athletes. So this localized pericardial fluid is not due to active inflammation, it's due to the chest wall abnormality. So now we go back and think, we've got a mild illness, we've got a normal troponin, really important part of this. The ECG changes were due to erroneous lead placement and the echocardiogram was normal. The subtle MRI findings are due to alternative causes. And so the athlete, after exercise ECG and after ambulatory ECG monitoring, which were both normal, was allowed back to competitive play. And the diagnosis of myocarditis was rescinded. So when we think back on the slides of the course last 30, 40 minutes or so, try and think of some take-home messages. Because involvement of a sports cardiologist is important in those debatable cases, but a lot of the routine return to play does not need specialist input. COVID is common in professional sports people, but severe disease is not. True COVID myocarditis with viral infiltration into the myocardium is very rare and generally is seen in those with severe COVID illness, those in intensive care, those who have died as a result of their disease process. The return to play cardiac clearance, so fitness and eligibility for asymptomatic, mild, and moderate, centers around the use of clinical review, so common sense, symptoms of cardiac disease, an electrocardiogram and an echocardiogram. Further tests are available if they're required, and a troponin is a very sensitive marker if used as a rule out. So if it is negative, the chance of being myocarditis are very low. If it is positive, you need to take a very accurate exertion history from your athlete, so you're not led down the garden path. That's a very British saying, I do apologise. If true myocarditis is found, a 3 to 6 month rest is warranted, and you can only return to competitive sport once the inflammation is settled and assessment of rhythm is favourable on ambulatory ECG monitoring and on exercise provocation. Thank you.